Tell me that works. Does that work? Just let me know if you can hear me. I've got a feeling that you can hear me now. Morena, yeah? Ka pai, kia ora. Now I don't know what to do. Should I start again? Okay. Yeah, I think I will. Take two. Morena whānau. Morena e te whānau. A ngā mihi o te ata ki a koutou katoa. Koutou e whakarongo ana mai. Koutou mai te timatanga o nei tauira. Ngā mihi ki a koutou. Koutou kātai anō ka tīmata. I'm reading kei te pānui au I tēnei pukapuka mai tēnei tākuta Joanna Moncrief, ko ia tētahi o ngā critical psychiatrists. And yesterday I talked about randomized control trials, meant to be the gold standard when you're testing whether a drug works or not. And the gold standard, say an antidepressant, will be given to a group of people and they are randomly selected according to very similarities. So there's not much difference between the two groups. They separate the groups. One group will get the drug, another group will not get the drug, and then they will test whether that works. Double-blinded studies are where the practitioners have no idea, that are working with both groups, have no idea whether they are getting the drug or not either. So here's the problems with randomized controlled trials. Having argued that the evidence of randomized trial is important, we need to be aware of the limitations of these trials and the ways in which their results can be distorted or misrepresented. We also need to bear in mind how the widespread assumption that drugs work according to the disease-centered model or drug action influences the design, conduct, and interpretation of the randomized trials. We should consider how the results of trials might be interpreted differently if we paid attention instead to the drug-centered model. So number one, outcome measures. We discussed the difficulties of measuring mental states and behaviours as if they're things that exist independently of the people who manifest them. Measuring scales used in trials of psychiatric drugs consist of fairly arbitrary lists of symptoms of a particular disorder. Each individual symptom is given a score that is meant to reflect its severity, and then the scores of all the items are added up to produce an overall score. Not very scientific, really. The symptoms included are not necessarily typical of or specific to the conditions in question. For example, symptoms such as agitation, which is like this feeling almost, some people have described it as a washing machine inside your body, but agitation could be different for you. And insomnia, which is difficulty with sleeping. These occur across different states of distress or mental disorder, are included in many scales. Moreover, many scales are deliberately designed to magnify the changes brought about by drugs of other interventions, but with no guarantee that the changes they detect are important to the people receiving the treatment. Unblinding. Although the use of placebos is meant to prevent people from knowing whether they're getting the real drug or not, it can be quite easy for people to distinguish whether they're taking the drug or the dummy drug in that situation. The drug being tested has, if the drug being tested has any psychoactive properties, then it will make people feel different in some way. People will notice effects such as sedation and mental clouding, for example, or they may notice physical effects such as dry mouth or nausea. People taking the dummy drug might be expected to feel some drug-induced effects or side effects and may notice if they don't. People taking part in such trials are particularly likely to detect if they are given the drug or the placebo because they are given detailed information about the process of the trial and the nature of the drug being tested, including lists of possible side effects. Thus, participants in randomized control trials are well aware that they might get a drug or they might get a placebo, and often try to guess which they have been given. They are also aware of what sort of effects the real drug might produce. Therefore, many trials that are supposed to be double-blinded are probably not double-blind at all. Indeed, it has been shown that participants in trials of psychiatric drugs can guess whether they've been given the real drug or the placebo more accurately than would be predicted by chance. If people believe the drugs they are likely to help them, which participants in trials often do, they may have a heightened expectation of improvement if they suspect that they are taking the real drug. Conversely, they may have lowered expectations if they believe they've been given the placebo. Hence, people allocated to take the active drug in randomized control trials will have different expectations of treatment to people in the placebo or control group. So any differences in the outcome of treatment may be due to the participants' different expectations rather than the pharmacological effects of the drug. Research also shows that health service staff and researchers can be unblinded. In other words, they can sometimes work out whether participants are taking the real drug or the placebo, probably due to their knowledge of the side effects people report. As reported above, this can influence their behaviour toward the participants, and they perceive and score outcome measures. Number 3, medication withdrawal effects. We usually assume that someone who takes part in a randomised trial of a particular drug is starting treatment afresh, unless the trial is specifically designated as a discontinuation trial, a trial to test the effects of coming off a drug. Yet this is often not the case. Trials of treatment for depression, for example, often involve people who are already taking antidepressants, sometimes for a long time. Trials of long-term or maintenance treatments always involve people who have been taking medication for months and often for years before entering the study. In these studies, participants allocated to the placebo group will be at risk of suffering from withdrawal effects and other adverse consequences of withdrawal induced by the discontinuation of their existing treatment. Therefore, many drug trials do not evaluate the effects of starting treatment compared with not starting treatment. They assess and compare the effects of stopping a drug with continuing to take it. We know that withdrawal from any sort of psychoactive drug has a number of adverse effects. These are described in more detail in Chapter 9, and they include acute withdrawal symptoms, physical and mental symptoms, protracted withdrawal, prolonged withdrawal symptoms, new syndromes or disorders caused by withdrawal, and relapse of the underlying condition precipitated by withdrawal, and psychological effects. The significance of the various complications associated with drug withdrawal depends on the nature of the drug and underlying problem for which the drug was prescribed in the first place. We used to think withdrawal symptoms were mostly trivial and short-lived, but now we know that they can be severe and prolonged in some cases. Even mild withdrawal symptoms may affect the outcome of randomized trials, however, because they may be mistaken for early signs of relapse. Agitation, for example, is a consequence of withdrawal from many types of drugs and also a feature of many different mental disorders. Discontinuation of some drugs can cause the onset of a new cluster of symptoms that was not present previously and can be viewed as a new disorder. Examples include the depression that can follow stimulant withdrawal and the psychosis that can occur occasionally after discontinuation of antipsychotics or antipsychotic-like drugs in people with no prior history of psychosis or schizophrenia. People with a diagnosis of psychosis, schizophrenia or bipolar disorder may also experience a genuine relapse of the underlying condition that is provoked by the experience of medication withdrawal. This effect has been demonstrated following the discontinuation of antipsychotics and lithium in particular. In some situations, it appears that the chance of having a relapse following the discontinuation of long-term medication is higher than it was before the medication was started. Alongside these biological complications of medication withdrawal, people may have become psychologically dependent on taking medication. Therefore, people who suspect they have randomised to placebo treatment may feel vulnerable and anxious about their medication being stopped. The evidence for all these situations is covered in more detail in Chapter 9. The point here is that studies that compared people who have just had their medication discontinued with people who continue to take it cannot demonstrate that medication in the first place helps to improve outcomes. It only shows that there may be a number of difficulties after someone stops medication. Some of these are related to the process of withdrawal itself and have nothing to do with the underlying problem. I'll stop there and just let you know that first of all, if you're on psychoactive or psychotropic medication and you're wanting to come off, please don't do it by yourself. Please make sure that you work with the prescriber, and if the prescriber is not available to you, that you take the information from the prescriber to your consultation with your GP or other prescriber. If you are and don't want to do this with anyone else and you're wanting to discontinue your medication, please don't do it alone. Make sure that your family, and even with your prescriber, make sure that your family or your network, whoever your whānau is, make sure that they are aware of your choices. If they disagree, talk to the disagreement rather than disconnecting. Try and understand what the fear is around, why they don't want you to stop. Engage and invest in this purpose. That what I'm reading at the moment is pretty heavy about how we test drugs so that they actually make it to the market in the first place. That will interest some of you, but not others. But in the drug, there are some ways that can help you think about withdrawing medication. And the reason that I say that is similar to what they just said, which was that you can come off the medication. If you come off suddenly, you can have withdrawal effects. Some people, including your whānau and your prescriber or your GP, someone may see it as a relapse and that you need to stay on them. It's like evidence that you need to stay on them. You too may also think, shit, maybe I shouldn't have come off them. So it is really important that you do it with your prescriber, with your whānau, with your network, and that you do it slowly. And what I advise GPs is 10% reductions. If you're on more than one psychotropic medication and you're wanting to come off it, say 3 of them, you get to pick one that you don't think is helping you, and slowly withdraw it at 10% reductions, so 10% of the actual dose, which is difficult, which is why I don't recommend you do it by yourself. And it's a long process. If you've been on the medication for a long time, it can take a long time to come off them, sometimes up to 12 months or more. So I just wanted to add that because that's my disclaimer. This is not me saying, quick, get off the medication. It's me saying knowledge is power. And if all of us are going to take responsibility in thinking about mental health problems, then we need to be up to date with the knowledge. And many people are not being given this knowledge. And so I recommend that you stay tuned. Have a look at some of the other readings that I've done in the beginning. I find the first 3 sections, the first 3 readings that I did were really helpful to give you an introduction. So if this is your first time listening, please jump on and have a look at some previous readings. And thank you for letting me know that that I had no sound. And ngā mihi o te ata ki a koutou katoa, koutou koe mihi mai. And I'm just staying on just in case there's some pātai, ngā mihi. I know, I was thinking that too, Maria. I was thinking that I needed to start again just in case someone tunes in later on and there's no sound, so they give up. But, those who persevere will be able to get the tail end of it. And lovely to see many of you who have engaged in Mahi Atua. Lovely to see you all join. And have a great day. Ngā mihi, ka kite.